The public is welcome to listen. The public should not address the board unless requested by the board. As a friendly reminder to board members, please note that some of the material contained in the agenda packet may be deemed confidential. In addition, the board should not discuss legal advice previously received or seek legal advice in an open session. Such matters will be moved into executive session for discussion. Members of the public will be asked to leave the meeting during the executive session. After an executive session, the board will vote on agenda items discussed in the executive session. Before I do roll call, I ask that everyone please let us know your preferred pronouns and put them by your name, I think in the Zoom window, if possible. And if possible, please add them to your title on Zoom. So should we go around and share pronouns? I'm happy to do that among those participating. I use he, him pronouns, and I will try to add those by my name. Someone like to go next?
I'm Sam Barami. I'm the Senior Advisor on Natural Medicine Services, and my pronouns are he, him, his. And you can adjust those via the change panelist appearance. So.
My name is Wendy, and my pronouns are they, them.
For some reason, it's not letting me do it, so I will work on that.
And I have so many windows open, so this is Tina Gonzalez, and she, her, or hers. Sorry. Did I freeze? No, okay. Too many.
Anyone else? I've also had trouble changing my name, so it seems like it varies in how that gets done.
We can have them go over it when we call on the non-voting participants.
Okay, that sounds good. Okay, so now I'd like to take roll call of the board members. I am here. Dr. Gonzalez.
Present.
Lundy.
Glad to be here.
Commissioner Buxton Andrade.
The commissioner is powering up their computer again to see if I can solve the issue.
Gotcha. Good. Dr. Goodwin.
He will be 30 minutes late. He is at the VA.
Sure. Thank you. Okay. So also I want to acknowledge, let me just check and see that.
Dominique and the DOR staff, and I believe Ian Sieb, who is a non-voting participant, are actually in MED, Marijuana Enforcement Division rulemaking, so they will be unable to attend this meeting. But I see the commissioner has joined us.
Sorry about that. Major computer problems today.
Joining. Okay, so just a housekeeping item as we get started. If everyone would please turn your cell phones to silent. And now I'd like to pass it over to Sam Barami for some comments.
Thank you so much. So before I introduce DOR staff present, I'd like to introduce Lori Bratton, the program director for the Natural Medicine Advisory Board. This is Lori's fourth day with us, and Lori will be reaching out to you all to schedule one-on-one meetings and talk about subcommittees and recommendations, and be an opportunity to get to know each other. So with that, I'll introduce Amanda Weirs from DORA, and Monica Sutherland, DORA, and Sarah Werner might join us later, or Kathy Duran might join us later. But for DOR staff, like I said, they're going to be in rulemaking today, so they will be unable to join us for this discussion. But I would like to pass it to the Assistant Attorney General to introduce themselves.
Hi, everyone. My name is Ashley Carter. I'm a Senior Assistant Attorney General, and I'll be serving as your General Counsel for this meeting. My pronouns are she, her, and I'm stepping in for your normal GC, who is Brian Uterenker.
Thank you. And I'll pass that back to the chair.
Thank you, Sam. Okay, so now I'd like to turn to reviewing the minute from the prior meeting. Let's review the meeting minutes briefly together. Then I'll ask for a motion to approve and delegate meeting minutes if there is no discussion.
This is Wendy. I think that they, somebody said that they'll move. I'll second it.
Did anyone hear a motion?
We still need a first, yeah.
Okay.
Here first, but Commissioner, if you want to.
I'll make I wasn't sure if somebody else did. I'll make a motion to approve the minutes as presented.
Think.
Good. And can we combine that motion with the motion to delegate the signature authority to sign the minutes on behalf of the board to Lori Bratton?
I think that has to be a separate motion as what they did yesterday.
They did it yesterday, but we can roll it in one.
Okay, then I'm good with that. It's a friendly amendment to roll it into one. I tried to do that yesterday and they corrected me.
It's presumptive.
Thank you. Is there a second?
I'll second Lundy.
Thank you, Lundy. Is there any discussion about the motion? Okay, all those in favor, please say aye.
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 Aye. Any opposed? Any abstentions? Okay, the motion passes. Now let's move on to the next agenda item, which is introduction of non-voting subcommittee participants. Perhaps sorry for the background noise. I will identify those who I can see in the Zoom. Maybe Dr. Jones, would you like to go first?
All right. Hi, Dr. Jones here, veteran and a neurologist. Good to be back. Oh, and pronouns are she, her, hers. Thanks.
Dr. Jones, Matt Druckmeyer.
Hey everyone, happy to be here.
You, Melissa Palmer.
Afternoon, thanks for having me. I'm a clinical social worker and I'm the director of Master's Science Palliative Care at the university, and I am she, her, hers.
Thank you. Rochelle Gailey.
Hey, thanks for having me. Rochelle Gailey with the Behavioral Health Administration, licensed addiction counselor and licensed social worker.
Thank you. Tristan Watkins.
Hi everyone. He, him, his. Deputy Director for the Business Support Division of OEDA and Director of the Cannabis Business Office.
Thanks very much, Tristan. Okay. So I believe that is, did we miss anyone?
No, you're good.
All right. So moving on to the proposed list of recommendations. Let me just sort of tee this up a little bit. After the last meeting, before this meeting, I took the consolidated list that Lundy had prepared that we all reviewed together at the last meeting, which was an aggregation of a number of different recommendations that we talked about and considered over the past several months, and tried to pull out the ones that, at least in my judgment, were not as dependent on the work of other subcommittees. That was one sort of criteria that I used. And another was those where it, at least in my judgment, didn't seem like we were going to be getting a lot of new information that would impact our consideration of that recommendation. This is, of course, just my opinion. So we'll go through each of these, of course, and get all the board members and the non-voting participants input on what you think about that. I did add back in the last version that I had, at least, of our definition of health equity, thinking that we ought to provide one as we move forward with recommendations, including some of these. There are references to health and health equity. So I thought for purposes of our work, it would be able to formally adopt a definition. So that is the background in a nutshell. My thought is that we can work through these. If there are those, of course, the board doesn't feel ready, or the subcommittee should say, it doesn't feel prepared to consider, we can table those for a future meeting. If there are other recommendations that subcommittee members feel really ought to be considered today, then of course we welcome discussion about those as well. So before kind of move into it, I want to pause and just open it up for subcommittee members or non-voting participants. If you have any questions about just sort of, this step and sort of the approach and, any feedback about this proposal for how we move forward with this meeting here.
Can I just add one thing? When you say rural areas, can you say rural and frontier areas? Because that seems to be a trigger point for some of them. The frontier areas don't have people that are getting services.
Thank you. Yes, and point very well taken. And we'll go through each of these one at a time as well. So if you have any other specific edits, we'll have more time during this meeting to talk about those as well. But I guess I just wanted to get a gauge of subcommittee comfort level with moving forward before we do. And I'm trying to.
If you need engagement, I'll say yes. I think we're ready to move forward.
Thank you. I'll take it. That sounds good. Okay. So I have script here. So after we have reviewed and discussed this section of initial recommendations, I will request that we vote on moving these recommendations out of the subcommittee and to the full board to review and approve these recommendations. I will ask for a motion to approve these recommendations if there is no further comment or action needed. So it looks like Sam and also to Ashley, there's sort of a possibility of considering these en banc, I think is maybe a term, like altogether. And I'm open to that. I guess maybe I want to look to subcommittee member feedback about that as well. There's some, biggies in here that I think that folks might want to talk about before we discuss them. But I guess I want to check first with the department and with the AG's office if there's like a preference or a reason for a preference of doing things together or individually.
Go ahead, Ashley.
I don't think there's a distinction legally. So if, whatever is your preference and whatever will work better for you guys. And just while I have the floor real quick, I think the citations in there should be 12-170. And I think they say 179.
Thank you.
Just bring that up real quick. Thanks.
All right. So with that, then I think it would make sense, and I'll try to go quickly. And of course, the degree of discussion, will impact that. All of which is welcome, but I think we'll go one at a time. And the first one on the list is the definition of health equity. So I want to pause and see if there's questions, comments, further discussion about the definition as drafted here.
No, I'll just say that I think it's consistent, and I think Dr. Gonzalez had, I think early on in our discussions, had brought this from HCPUF's, HCPUF, but I think it's also consolidated in CDPHE's definition for health equity, and I think if we can stay as consistent with any state agencies' definitions that have been adopted in rural or by their boards, I think it's a good idea.
Yeah, I thank you for that. And I do recall we began with a draft from some joint work from, I think it was the CUP and CDPHE and maybe some other state agencies. I believe I recall that we modified it some to make it a little bit more kind of positive language in terms of the recognition of one's race, et cetera, being an important part of achieving health equity. But I do believe that the impact of this is very much in line with the definition that HICMA and others are using at the state.
I do have a question for the commissioner. And I just wanted to reflect it on the document that I have downloaded in Word for this. You said to include in this document rural and frontier areas specifically?
Yes.
Okay.
It's just becoming more and more as we go through different subcommittee meetings, and not just on this one, that frontier counties, their role is talking like the rural areas of Douglas County, but we have very frontier counties that do not even have access to service in Southeast Colorado, like Baca County and Kiowa County and stuff like that.
Okay.
And so they've asked for distinction of that.
Okay.
And I guess a question for Ashley, maybe we should vote, we should have a motion to adopt the commissioner's edit wherever the term rural appears in these recommendations, and also maybe go ahead and vote on your edit of the correction of the citation before we vote on any recommendations that need those edits.
Yeah, you could do that. I think, kind of whatever's easier for you, because I think you could also just make the motion at the end as amended, as discussed.
Maybe that's easier. Dr. Gonzalez is here, so.
Yeah, just a quick question, and I'm not too sure. Some of the other documents that subcommittees are putting together, they have it watermarked that says do not share unless verbal something. To do not share without permission of the committee. Is that something needed on all documents until they're finally approved?
No, so I think all documents are subject to QORA, right? Like any of these documents, right? Or any document is subject to QORA. So even, labeling it do not share does not mean it's protected from a QORA request. So I don't think it's necessary to have anything in there like that.
Okay. May I have a motion to approve recommendation number 1? And with, I'm going to ask that with the subcommittee's approval, I will dispense with reading it, or do I have to read it for legal purposes, Ashley?
I would move to approve and dispense of reading it.
Thank you, Commissioner.
I will second. Would love to hear Billy read.
Fireside meeting.
Torture.
All in favor? Aye.
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 Is anyone opposed? Are there any abstentions? Okay, the motion passes. So we'll move to the next item. I should add that these are in no particular order among those that I elected. So for the second one, this relates. Oh, Blondie, please go ahead. Or no? You should take your head back down.
I have a question, but you can explain first.
Okay. So the purpose of this recommendation is to promote the approval of licenses for those who want to participate in the delivery of natural medicine services, and do so in a way that fosters access among marginalized communities. And the model that I had in mind for this is like the National Health Service Corps, where there are incentives provided to clinically trained professionals to go to rural areas, for example, to deliver healthcare services. So this is, I guess I would say, there's not a specific must do in my, as I tried to craft this, because, first of all, there's not like direct state funding involved. There's not direct state, there's not like a legal mandate for the state to create sort of separate pathways for licensure approval. So it's a recommendation, though, from the subcommittee and hopefully from the board or the state to give some priority and to basically create a process by which those who commit to serving these communities can get expedited consideration or sort of something like that, some sort of an incentive or some sort of prioritization in the application process. So that's the recommendation. It does leave the details really to the state to figure out what would be most effective in this area. Wendy, do you have your question? Yeah, go ahead, please.
Yeah, I think maybe I have more of two concerns. First, I think my concern is the significant amount of bias with which this could be implemented, right? What does this commitment mean to serve these populations, and what does discounted services even mean? And I think that the equity piece with training programs that I'm far more concerned about are related to underinvested practitioners that are receiving the training. So I almost wonder if this recommendation is twofold, one that's provider oriented and maybe one's community oriented, because I think that there's far more of an equity compelling case for the state to incentivize training programs that discount services to underrepresented practitioners, providers, lower SES providers, so that there's also more diverse representation within the field. And then perhaps separately, some kind of incentive for saying you're going to work with these communities. But I just think tracking what it means to work with, because there's a case to be made that everybody's going to be underinsured when it comes to natural medicine services. And that even $1 discount is a discount to services. So I'm hesitant to approve this recommendation as written, because I don't have confidence that it would actually be equitably implemented. I think people would try to find workarounds. And I'm actually more concerned about the cost of training programs to facilitators themselves, and want to see training programs create discounts for those folks.
Thank you for that comment. Partial response is certainly welcome. Revisiting this recommendation in a different way, revising it, splitting it into two separate recommendations. We do have a potential recommendation for a social equity program for licensees who, meet certain criteria in terms of their background to get additional support in the licensing process, technical assistance, loans, grants, and so forth, and loans and grants for launching their businesses. There is an intent here to include where it says incentives that could include discounted tuition and loan forgiveness. So it does try to speak to some degree to the costs of becoming a licensee. I agree there could be a lot more detail here in terms of how this program is designed. I've kind of intentionally refrained from that because I guess there's just a question about how deep into the details of specifying the program the board should be. But I think if your concerns, I mean, if you read it as potentially inequitable, then I am concerned about it as well. So I'm in favor. I guess I just wanted to respond to your comments, but I think I would support tabling it so that we can have a closer look and maybe some, taking a different route or whatever.
Yeah, okay if I respond?
Please.
Yeah, I think tabling is fine. And I just want to be clear that I don't think it's about adding more detail. I think it's about, for me, how it's focused on who the facilitator is serving rather than who the facilitator is themselves. And I think that there's absolutely a case to be made for how we can incentivize providers committing to serve underserved communities. But I also think the licensing and the training are the two most prohibitive costs for facilitators. Training programs that I see currently advertised are averaging $5,000. So that's where, for me, equity, if we don't start upstream there for the cost of the training itself for these facilitators, I don't have confidence that it's going to translate to high quality, culturally informed services to those populations and those clients. So that's the conversation. I think we either need to create multiple recommendations or somehow address that. And tabling it for now is fine with me.
I'll let Melissa Palmer, please go ahead.
Oh, thanks. And I apologize. I was really sick last month. So I'm sorry I had written a bunch of recommendations and was out sick. One of the things that I was thinking about, and it kind of dovetails with what you were saying, Lindy, is when I was looking at the community college distribution online, and I noticed that not every county has a community college, right? And so the people in the more rural areas will have an inequitable access to the training. And I think that we have to find a way to make sure that that's balanced. I'm not really sure what kind of recommendations we can make for that to ensure that maybe we can partner with some of the counties in the rural and the frontier areas to make sure there's a training. So that was one of the things I was thinking about for the equitable education piece for the folks who will be providing these services.
Great, thank you very much. Go ahead, Dr. Gonzalez.
This might be a twofold question, and I think Lindy sits on the training education subcommittee. But is this something that we're just recommending, and then that committee, if they're building the facilitator training modules, would kind of take on and then kind of embrace or grab the sentiment and actually put in theirs? Or is this something that we're doing separate that won't kind of not contradict, but kind of duplicate what that subcommittee is trying to do? So that's the first question. And then the second question, has it been decided? Because I've heard two different conversations for facilitator training, depending on what that training looks like. I know that Dr. Estes had brought up the fact that the psychotherapy to kind of get licensed as a psychotherapist in Colorado, you go through DORA and you do their training and you pay their fees. So I wasn't too sure if it was going to live with DORA or if it was going to live outside with a separate entity, because I think that's going to drive some of those fees. Whereas if you have a mom and pop shop technical college or group, then of course their costs are going to be more. Rather, if it's a state entity, they probably already have those overhead costs that are covered. So it would just be the training itself. So twofold question.
Yeah, so I'd like to touch on that. I think we're kind of conceptualizing this training program and the approval of it, right? In that subcommittee, I think what we want, we're statutorily required for the educational pieces. What we're required to look at, right, is the education training on participant safety, drug interactions, contraindications, mental health and state, physical health and state, social and cultural considerations, preparation, administration, integration, ethics. and they must not require a professional license or professional degree other than a facilitator license issued pursuant to that article. So when we're thinking about approving training programs, we're thinking it's at DORA, it's at DPO. The director is approving training programs. The question that we have is, what is a role for higher education in this process when we get into the nuances of potentially auditing, right? Or and this thinking later years of like how they license and approve like occupational schools and the testing requirements for those. For those schools or what's approved, I think we're thinking about like, of course, having a test for this program, right? Like for occupational licenses in this division, in this program, similarly for this program around a test for familiarity with state law. So for the rules for this occupation as well. So it's kind of two-part, but right now we're thinking it will be approved by the director of the division and Lori in approving training programs and who's accelerated. And when it comes to like additional schools or what we can do with the training programs and what the division can do or the agency can do, we might have to involve other agencies in how those programs are managed. But right now we're thinking at the division. So what I guess like when it comes to like partnering with, you know, community colleges, I think that's definitely just discussion we should have on like access to the educational programs. I think there's nothing in statute that prohibits these approved training programs from offering the courses that they can online. Knowing that there's going to be required like practicum or observance, right? So that would probably have to be in person, but I think that will be for the discussion for the qualifications, licensing, and training. But if we're thinking about number 2 right here on like the prioritization of accreditation of facilitator training programs that offer incentives, what does that look like when we're trying to review training programs? Should we ask, or should a part of this recommendation be that any training program that, you know, should there be a rule or a recommendation for training programs to have a plan on how they are offering incentives, what that mechanism is like, what the funding is like, what are options for loan forgiveness, and how would they have facilitators serving these communities as part of the plan when they submit for an approved training program to fit this criteria of prioritization? I think that's something that we should think about for this recommendation. Like, should we require them to submit a plan, an equity plan with their approved training program? And how do we make sure that they are adhering to those requirements?
Yeah, I think that's a great idea, Sam.
Sorry, I do want to offer opportunity for Lori. If Lori has any thoughts on this. I know it's your fourth day, so I'm not expecting you to answer this, but would like to hear it if there's anything that the board members in the subcommittee should consider when looking at a recommendation like this, and how this division could potentially implement it, or if we need to involve another agency like higher ed.
I do think that higher ed has the experience and capacity to do the review, and that it is in our best interest to, at the minimum, consult them about what that looks like. We should do that, because undertaking something that may already exist out there for us to create something, I mean, that would take a lot of effort. So best get their recommendations, their thoughts on it, and if they can support in doing this. You know, there's when you talk about loan forgiveness and we talk about some types of grants and funding, some of those are all connected to federal stuff. So we do have those challenges also, that there may be issues involved. So I do think that reaching out to them and talking to them is probably a good next step for us.
Yeah, and I'm happy to do that. Reach out to, I think it's DPOS at Higher Ed.
Thank you. Dr. Gonzalez.
So I think Sam answered my question. Did I send you information, Sam, on Dr. Bynum? He's a professor at Anschutz, but he created a health equity certificate program. And I'd be curious to see kind of how he did that process, one, and two, how they put a cost to getting that certificate for people who are either alumni or non-alumni of Anschutz. And I'm curious if that would kind of play in here. And then second question, currently does DORA have a process as to who builds your curriculum for professionals to come in and take those certificate courses and then take the test to get licensed?
The answer is that we don't build curriculum in general here. We work with associations and agencies that have approved curriculum, and then we lean on them for guidance and approval on what's the standard in any occupation.
Sure.
Thank you. Ms. Palmer?
Thank you. From the education standpoint, for our certificate and at the University of Colorado, there's in-state and out-of-state, and often, unless it's not part of the, considered a part of what I'm trying to say is that there are set costs. I mean, some of the programs have some adjustments, but usually these costs are, like $800 a credit versus $1,100 a credit for outstate. So even with that fairly reasonable cost, I mean, if it's a 12 credit certificate program, you could see how that could be not something that could be affordable by a lot of people. On the other hand, one thing that could happen is that you could develop a curriculum, like how get a team together to develop a curriculum like we did, and then you can replicate it. So you could have, say, like all the community colleges or wherever the community access to education. So that might save, if you have one curriculum that incorporates all the elements that you want, that might be a way to save some costs and make it more marketable and manageable for people to attend, and it could be asynchronous. There's a lot of different education things that we can do to help with that cost.
That's great. Thank you very much. So my thought about this recommendation is that those interested can send thoughts to Sam between this meeting and the next one, or maybe to Lori, I guess. I don't know, or both. Lori.
Oh, be great.
Or is our person now? Is that correct?
We're working together still.
Okay. So both or Lori, I'll say. And we'll pull those and we'll review the different suggestions or recommendations in this arena at the next meeting. So unless I have to, I'm not going to call on this recommendation. I think I can move on. Yes. Okay. I see a nod. All right. So number 3. So this is a bit of a modification of a prior draft recommendation relating to Medicaid coverage of psychotherapy and other services delivered in conjunction with natural medicine. And in the course of, I guess, the last month or so, it became apparent to me that there is a provision in the Natural Medicine Health Act that, now this could be my interpretation. I don't know if you want to put the language in front, or maybe if you want to modify my interpretation or read the verbiage to the subcommittee, then I would certainly support that. But in brief, it requires the state Medicaid program to pay for substance use disorder services and behavioral health services that are delivered that would otherwise be covered by Medicaid, so delivered by an otherwise qualified provider in an otherwise, eligible context, i.e. a Medicaid enrollee in the state, even if those services are provided during a natural medicine session. So this is not coverage of natural medicine, i.e. in this case psilocybin, and it's not coverage of natural medicine services per se, but it does require the state to cover substance use disorder and behavioral health services that are delivered in conjunction with natural medicine services. So the recommendation is for the state to go ahead and begin the process of figuring out how it's going to honor that requirement in the Natural Medicine Health Act, and to kind of prepare the community, in particular the community of Medicaid providers and patients or enrollees, that this opportunity is available. And because these are existing services that are already covered by Medicaid, there's no need for new codes or things like that. It's more, in my judgment, about a kind of programmatic preparedness and community-wide preparedness that this requirement exists and can be utilized once the Natural Medicine Program goes live. Are there questions, comments, or Dr. Goodwin?
Hey guys, sorry I'm late. Had a little scheduling conflict. I'm here now. So yesterday during our emergency response subcommittee meeting, and Dr. Gonzalez, I'd like your feedback too, and Sam, they had Steve Cox come in. I think he was from CDPHE or something, and he was talking about how, I don't know if it was federal Medicaid or state Medicaid, but basically if a Schedule I drug was involved, a facility could lose their ability to receive Medicaid funds. So he's talking about, like, say there's a facility that does end-of-life services, and you couldn't bring, like, say, medical marijuana into that facility if they receive Medicaid funding. And he was pretty adamant that any Schedule I drug by the federal government would cause this problem. And I'm curious if we're going to run into this issue here, or if this is different with state versus federal Medicaid. Dr. Gonzalez, Sam, you guys want to jump in? You know what I'm talking about? Thanks.
So, Billy, do you think it would be helpful if I read the section of that statute?
Sure, please. Go ahead.
So, what Billy is specifically referencing is in Section 12 of SB 23-290 in CRS repeal or reenact with amendments 12, 170, 113 as follows. And I think we need to correct. Do we need to correct that? No, we don't. So it's in the protection section, subject to the limitations in this Article 170, Article 50 of Title 44, but notwithstanding any provision of law. Section C, it reads mental health care, substance use disorder, intervention services, or behavioral health services otherwise covered pursuant to the Colorado Medical Assistance Act, Articles 4 to 6 of Title 25.5 must not be denied on the basis that they are covered in conjunction with natural medicine services, or that natural medicine and natural medicine product are prohibited by federal law. Insurance or an insurance provider is not required to cover the cost of natural medicine or natural medicine product. So this is what Billy is specifically referencing, and reached out to HICPUF. We have had follow-up. We brought it to their attention. I mean, that's an argument right there. I think we need clarification on how this could work, right? I think, I don't know. I'm very interested to see how this would work, but it's there in statute.
Yeah, great. Thanks for reading that. I just, I didn't even think about it until he brought that up yesterday. I didn't even know that was an issue. And so I was just curious, if there was going to be some conflict there. Anyway, thanks.
Yeah, and Billy, I know you're the expert in the insurance field. I think, this is, I want to make sure we understand this is state Medicaid.
Yes, but Medicaid is funded, is a joint program really between the state and federal government. States implement the vast majority of the policy, but there are federal parameters, and the majority of the funding comes from the federal government. So there certainly are federal contingencies. My opinion is that, this section addresses the, as kind of what I like to say, everything else that we're doing. There's the overhang of the federal illegality of the substance and, everything related to it, basically. Kind of my position on this is because the provision is in the law, and because there likely will be scenarios where a Medicaid provider will deliver mental health, et cetera, services, to a Medicaid enrollee, in a natural medicine context, then we just want to make sure that the requirement of this law gets implemented, and that HICPUF, et cetera, is prepared for that scenario, as they are required to be by the National Medicine Health Act.
So for number 3, what you're asking is for the state to clarify and essentially show a pathway where this could be billed. Right?
Correct.
Yeah. Does anyone have any thoughts on this? Anyone who might work with folks or billing? Yeah, Tina.
Not thoughts, but Rochelle, I don't know if she's still on from the BHA. I'm wondering from a licensing component from the BHA, because Medicaid's about to change and look much differently in 2025, where you're going to have the Medicaid contracts to do the physical health, and then you're going to have the behavioral health administrative service organizations doing the behavioral health. And I'm kind of curious if this could both fit in HICPUF as well as the BHA as a method to get services covered, because the BHA also has grants that they give that Medicaid historically doesn't cover some services. Then the grants will kind of step in and help pay for those services for agencies. So I'm kind of curious if she has any thoughts, or if she left yelling and screaming out of this meeting with these questions. Oh, there you are.
No, I'm still here, Dr. Gonzalez. I would have to double check with our finance team in if there were any opportunities to address this. A lot of our available funds, are identified for specific populations, specific types of treatment, but I think this is a great opportunity to try to bolster our ability to assist with this further. So thank you for bringing it up, and I'll take it back. And if I get some information, I'll be sure to share it with this team.
Thank you.
Thank you very much.
I guess I just have a question, right? Like, arguably, you could bill for the mental health care or the substance use disorder and not bill for the natural medicine piece. Those could be separated, right? I think I need clarity on how billing works, but I think it's a good recommendation, and it should definitely happen in the sense of, like, we need clarity on this. We brought it to HICPUF's attention. They said they were reviewing it. I've asked for a follow-up. We'll see what the follow-up says, but it's in statute.
I'd say one point, just kind of in hopefully partial clarification of that, and then Dr. Goodwin, I see your hand is up. But one way that I think about this is that, okay, a Medicaid enrollee has decided to avail themselves of natural medicine services. They go to, let's just say, a healing center. They sit down with a facilitator. They ingest psilocybin, and at some point during their experience, a licensed psychotherapist delivers whatever the standard, let's say 50 minutes of psychotherapy to that person. And that psychotherapist is a Medicaid provider and, bills Medicaid using the standard billing code for psychotherapy services that they would have used if the situation had not been in a healing center in the natural medicine context. And so the mechanics of the billing or the service are identical to what they would be outside of this context. There's no need to, until Medicaid decides to add a new benefit for natural medicine or natural medicine services, there would be nothing to bill for in those regards. They would simply be billing for the pre-existing approved benefit of psychotherapy. Dr. Goodwin.
Yeah, and just a caveat that we're at the very limit of my knowledge on this. I don't know a lot about it, and that's kind of why I'm asking these questions. But this thing that Steve was talking about yesterday, it sounded like, past the billing part, that if it came to light that this facility that accepted Medicaid funding brought in this Schedule I substance for any reason into their facility, it could risk their ability to participate in the Medicaid program moving forward, right? If it came to light, that's the way I understood what he was saying. But Sam, you're shaking your head. Is that kind of the read you got off of it too? That
There's just an inherent risk with all of this, right?
Yeah, right. And so that's what I'm curious about. Is that the same case with psilocybin? If we did, because it did sound like there was some protection in the law here that may prevent that. But anyway.
Matt, do you have any thoughts on this?
Yeah, there's protections in state law, but the state law can't protect us from federal law. So I'm hearing this conversation and I'm wondering if there's been any outreach or communication from the state on any level with the feds on any level. I know there was similar, in the Oregon law, there was a requirement that the OHA reach out to the feds to discuss the discrepancy between our state and federal drug laws. And the DEA basically said, thanks, yep, we know what you're doing, and left it at that. I think this is an opportunity for us to, this gets repeated pretty regularly, that there's an inherent risk in working with Schedule I drugs if you have a certain prescriber license or this and that. And yes, I agree with that characterization, but we are the ones that should be drilling down into what is that risk? What does it look like? Clarifying, reaching out to other agencies, whether within the state or at the federal level, so we can get to the bottom of this. Hey, we're not trying to hide this. This is public. We're doing a new thing. What is this? How is this going to impact X, Y, and Z?
Lenny, I hand it to you.
Yeah, I just want to briefly insert into that. I think that, and I don't want to get off track from the HICPUF conversation, but I think we need to reach out to any federal entity where there's inherent crossover, because these are the same issues with banks. These are the same issues with payment processing. Whenever you are inherently crossing the state and federal law, there's a lot of roadblocks. And so who do we need to talk to beyond the DEA to make sure that we are eliminating those things as much as possible as far as roadblocks?
Yeah, we can continue to do that.
Yeah, I recall at a prior subcommittee meeting or full board meeting where we talked about reaching out to the to call them again, the U.S. Attorney for the state. I don't know if that's the right door, but I do remember that this issue has come up. So I guess one thing I want to say in partial response to your concern, Dr. Goodwin, is that the vast majority of healthcare facilities in the state hospitals, community health centers, and so forth, are Medicaid, recipients of Medicaid dollars. And you're absolutely right that they'll have to make a judgment about the risk they're willing to take if they want to get involved with the delivery of natural medicine services. So is the case, and I don't say this to diminish the risk that you are, I think very importantly pointing to. But every single person who hands psilocybin to anyone else in this context is subject to federal prosecution. So I don't say that to dismiss these concerns, but I do have a feeling that we should sort of forge ahead with our program as best we can, with acknowledging that everyone who participates is going to be subject to some degree of federal risk, federal legal risk. So on that cheery note, are there any other discussion or questions about this recommendation? Would need to have the citation revised for Ashley's comment. It should be 12-170, not 179. And I would also propose to include, there's language at the beginning of what Sam read, where before substance use disorder services, the statute references mental health services. So I would want to make sure that phrase is also in this recommendation to just make sure it captures all of that, the language relating to the services that are covered by this requirement.
I can add that section in into the Word doc for the amended one. I've been tracking those edits.
Thank you. All right, so if there's no further discussion on this initial recommendation, then I'll move us to vote on these recommendations. This is a reminder that voting and discussion is only for members of the board. So may I have a motion to approve recommendation number 3?
So moved, Dr. Goodwin.
Dr. Goodwin. Is there a second?
I can second. This is Tina.
Thank you, Tina. All in favor, please say aye.
Aye.
Aye. Anyone opposed? Any abstentions? Okay, the motion passes. So we'll move on to the next item, number 4. So the state is required to deliver a report every year about the status of the program. And so this is a recommendation that that report include a assess of, in short, the equity of access to natural medicine services in the program. I want to open it up to questions, comments, feedback about this recommendation. Dr. Goodwin.
What would you expect, like the cost associated with doing something like this? Manpower, software. I mean, like I don't even know what the health equity assessment would look like. I mean, can you just kind of explain to me really what you envision and what you think what the bill would be on that?
So definitely out of my expertise to give you a number, maybe let me kick that to Sam, and I'm happy to comment more kind of qualitatively about what I think it would look like. But let me hand it to Sam first.
Yeah, I think, that's basically what I was wondering, right? Like if we require a health equity assessment, which I think should be a part of the report. My concern is like, what does that look like if we get into the specifics of like how the program does that? Because we're a fee-based program, like so any additional rules or things that we may require the program to do will be reflected on the license it is. So I think it's a good idea. I think we should maybe add a line in there to the best of its ability. And possibly in partnership with another agency, or if we can add anything in there, maybe direct asking another agency to do that. I don't know, Lori?
Yeah, I think that adding in another agency or actually outsourcing that to obtain some of the data from somewhere else, whether it be several agencies or not, that is going to be the most cost-effective way for us to obtain the information. But I believe it should be included, absolutely.
Thank you both. Lundy?
Yeah, actually, I don't think it's wise to require the state to be the one to create the health equity assessment, because I'm also aware there's so many institutions that are already created for state-based research and national research in this space. So perhaps the recommendation can be focused on that collaboration to receive health equity assessments from other institutions that are doing that work. One example that I know I included in my draft of equity recommendations was the Colorado Health Institute. I don't know what assessments they're doing specifically around natural medicine, but I think they are a state research entity within the health sector in particular. So I'd be curious to reach out to them. I'd be curious to receive from MAPS, research institutions that could provide us with these kinds of assessments, or any other research organizations that currently exist. I just don't think adding more work is the idea. I think receiving the work that is already being done and just knowing all that goes into data collection. And I imagine, Dr. Goodwin, we would be asking for a lot more of human power than we realize when this work's already being done. So perhaps the recommendation is to receive these assessments and include it in the annual report.
I want to touch on what Lundy just said. I think that's a great idea. I think another option to include with that is the mandatory data that DOR is going to be required to collect as well. I think when speaking with DOR, and I wish they were here because this is something that we've discussed, and I think they've mentioned at Products Research Data and other subcommittees, is as well as when they were discussing prioritized subjects for their listening sessions, and they have a listening session on data that is going to come up in November once they're past MED rulemaking. But what data would we like to have, right? What data sets should we be looking for? And that could be part of the recommendations there on a health equity assessment, or what data sets they should be collecting in conjunction with CDPHE, who does collect data on this. So I think we can table this one for right now till we get into that data discussion. But I think there is an opportunity to include a health equity assessment to the best of our ability in any form of data retention or collection. And maybe it's part of, I think when we were early on talking in the subcommittee around the, Dr. Gonzalez, correct me if I'm wrong, it's like the Rural Health Equity Commission.
Yeah, I was trying to find it. I've sent you so many. So many attachments that I forget. But I was trying to pull it up to remember who actually published the Rural Health and Health Equity for Colorado.
I think it's at CDPHE now. I think it was at HICBUF, but I think it's at CDPHE, but I might be wrong.
Yeah, I'll try to dig it out.
But I don't know, Chair, what do you think about, like?
I'm happy to either table, or I like the idea of saying something like in collaboration with other departments and in leveraging publicly or I guess I would say privately produced materials like from CHI and MAPS. In my opinion, and I'm happy to be in the minority, is that the state's going to have more primary data on this program than anyone else in the world sooner, and they're going to be producing an annual report. It seems like it would be amiss to not direct them to include an equity assessment in that report, in my opinion. It would be kind of a gaping hole if they're going to be commenting on the status of the program to not consider the equity in which it is implemented. But that's my take. Yes, Lonty.
I wholeheartedly agree with you, Billy. I think that there needs to be some clear measure of the inclusion. I just think that not putting the burden on the state producing it itself, but collaborating with other institutions to receive it, so it doesn't have to be on the fiscal note. That's where my consideration is. But the requirement of a health equity inclusion, I don't think that's an option. I think we're missing the glaring issues and dynamics of this industry, as well as dynamics of being not yet federally legal, if we don't include those considerations.
So when we say in like towards the end, right, in collaboration with other state agencies, private or public organizations or institutions.
Sounds good. And I'm happy to also include some kind of feasibility language, as long as like if you say to the degree feasible, is it possible the degree feasible is 0? I want to be like, it could be to the degree feasible, but not ignore it altogether.
Yeah, that's what I was thinking about, like that data discussion, right? On like what data sets we would like to have and like how do we receive them. I think I was talking to Kristen Spear from the Psychedelic Pharmacists Association about, even when someone, people come to retail pharmacies not wanting to go to an ER to receive a huge bill to talk to a pharmacist, right? And like, or someone in crisis might come there. So like, how do we, and I know pharmacists are like super understaffed and can't always just like, oh, I'm going to enter some data in, or like, how do we collect that information to know, this is just an example, by the way, right? Like, know, or how do we make that publicly available where people could report, and where do they report, and how can we see that reflected, right? And I think that should also be part of public education campaigns and like materials that are produced, so we can actually see like the full field of view. But I think it should be 100% part of it. I just want to make sure that it's not specifically on the natural medicine program, because I don't want the cost of licenses to go. But if there is some set of requirements for this specific program or agency to do so, right?
Great. So do we want to take a month to kind of refine this one to get the language clearer in terms of what would be, maybe we don't do any harm in terms of licensing fees, et cetera. So maybe we table this one as well. I don't know if folks feel for that.
And I think we should discuss it at the full board meeting as well.
Okay.
I don't know if we voted out of here, it doesn't mean we can't edit, right? Like, where the full board can't.
It's not a final recommendation.
Yeah, it's not a final recommendation, right?
So do you want to read it back as you have it now, Sam, with the?
Yeah. So I have everything in there. When we get into those in rural and frontier areas, those with disabilities, indigenous peoples, racial and ethnic minorities, and those who identify as LGBTQIA+, in collaboration with other state agencies, private or public institutions, or what's a better word for that? What do you think? What's an institution?
Organizations.
Yeah.
Institutions. I don't know.
Organizations. I think that's good. To the best of its ability. I don't know. We can workshop this. I don't want to waste time. I know folks have got to run. So, in collaboration with other state agencies, private or public organizations, to the best of its ability. And I think that language around like the state we're not specifically saying DORA, right? Or DPO, right? I think we just come back and say like how, right? So I think that's fine for now. We can. Okay. Yeah. All right. Well, I'm happy to have a vote on it with the acknowledgement that we're going to be, it's not final, as it is the case with all these, before it gets to the full board for additional discussion and review.
So if there's no further discussion on this initial recommendation, then I will now move us to vote on this recommendation. A reminder, the voting and discussion is only for members of the board. So may I have a motion to approve recommendation number 4?
As amended.
As amended, thank you.
So moved. Lundy.
Thank you, Lundy. Is there a second?
Yeah, I'll second it, Dr. Goodwin.
Thank you, Dr. Goodwin. All in favor, please say aye. Aye.
Aye.
Aye.
Is anyone opposed? Any abstentions? Okay, the motion passes. So we'll move on to the next item, number 5. Since it's short, I'll just read it. The state should allow licensees, and this would be any licensee, healing center, facilitator, cultivator, to pay licensing fees over a period of months or years rather than requiring payment in full before the license is awarded. I believe this recommendation originated with Lundy. This is kind of my effort to kind of put it into action. Yes, Lundy, please share more.
Yeah, I have a couple concerns as written. So my recommendation really centered on the state collaborating with a institution such as a firm, some kind of payment institution that would still allow the state to receive the license cost up front, because my understanding with the cash program is that it's a cash program. And so I think as written, it would just get completely nixed because it wouldn't allow the state to get the full cash amount up front. So my recommendation is really more around finding a solution that allows us to honor the cash program while also decreasing the upfront cash burden on the facilitators themselves. Amanda, you gonna dash my dreams?
I'm hoping not to. However, unfortunately, this is where I sit with Dora, right? Like, so we do all of the fiscal and financial stuff for all of the programs. They are cash funded, exactly as you say. So without the ability for the licensee to somehow deliver the full amount of funds to the program, there is no program, right? We can't do anything. We can't pay fees. We can't run Zoom. We can't do anything. We don't have a board to oversee to make sure people are doing what they need to be doing. So the mode would have to be through a firm, different payment plans and such. It has to be delivered to us as a whole. There's one exception to payment plans, and it's when the licensee has been disciplined and there's a fine associated. Some of those costs can be high. So we do allow a payment process in those situations, but not ever for a first-time applicant or for a renal. So I hope I'm not dashing your dreams, but that's the reality.
No, that reinforces my point.
I actually have a question for Amanda. And maybe this isn't relevant, but like, would there need to be a procurement process or allowing a firm or someone else to be an accessible payment portal, or
potentially, yes. They would have to work with our vendors that we use right now for our payment processing. If that was something they were going to do, like right at checkout, like, hey, maybe I can get financing right here for this, and then a firm sends it over or what have you. So they would have to work with our current payment processing vendor to do so. And then there might be some contractual things involved, which we can definitely do with our folks that take care of that as well.
Okay.
I think about like when you're on like a website, right? Or even like an airline, right? You're going to pay for your airline flight and they're like, oh, but hey, you can pay with a firm right now for 6 payments of $70, right? So that would have to be built into our platform. Perfect timing as we're working on building into a new platform right now. And then working with our payment vendor to do so.
Do you, I'm sorry, I'll just quick follow up to that. I mean, do any other licensing programs do that? Like, do we have a model we can follow for this?
With Colorado? No.
Yeah. Oh.
We would be the trailblazers.
Okay. And just to follow up to what you said, I understand it's a cash program. That doesn't, to me, per se, prohibit payment over time, first payment lump sum up front. Is there a specific law or regulatory requirement that payment has to be made up front and whole?
So we look at what licensees pay every single time they're due for renewal. So some programs renew on a 3-year basis, some of them on a 1-year basis, most on a 2-year basis. But we are required to make sure that we're not keeping any excess funds. So we're checking those consistently. So when we're looking at what it costs to fund a program, that's all of the staff that it requires. It's for this particular program, we're going to have peer fees associated with it. Just based on what kind of work that these folks will do. We have fees associated for being able to utilize our programs, right, to go online, print out your licenses, access documents, those kinds of things. We look at those so closely with a fine-tooth comb, and so typically they're going to fluctuate. This first go is going to be the hardest one for the licensees when we first launch this. It's going to hurt really badly. However, we're going to look at it in another 2 years, right? Once we've had people from Oregon endorse in, and we're rolling with it, and it's going to be a completely different cost. The pandemic is a perfect example of such. So when everybody was in office and, it was a full-time thing and everybody's electricity was doing, driving up costs and costs of different goods to have in office, most of our license fees were a little bit higher. We've dropped them significantly over time. $180 renewal for a registered nurse is now $44, right? So we're always looking at that. Like, that's kind of the point, was we need to make sure that we're not padding pockets. This is the state, right? This isn't a business to keep padding pockets of such. So when you're funding the program, there's so much to look at. So it's hard to tell you that, Billy. I mean, we have a set number of FTEs, full-time employees, that are for each program. And so we're looking at those costs up front. So if we don't get the costs up front from our licensees, who are we borrowing from, I guess, to pay for the program to run, if that makes sense?
Thank you. I get it. I appreciate that response. Rochelle, thanks for your patience.
No problem, thank you. I just wanted to throw out one idea. I'm not even sure if it's feasible, but I figured why not. I know that PayPal allows you to select a payment program of 6 months when you make purchases sometimes. And I wasn't sure if the state would be even able to look at that as a resource. I honestly don't know how it works in the commerce and business setting, but just thought it might be an idea as a payment option on that website where the user could pick PayPal and then they could finance that themselves through that portal, so to speak.
I don't see why that would be any different than working with any other potential processing service, a firm or any other, third-party vendor. I think that there's an option for all of that.
Just really quickly, I will comment that the Department of Revenue does do that because they use PayPal as a portal, but I don't know if it's specifically the payment plans, say for taxes, are through done that way. I think that might be separate.
Lori, please.
I just want to add to if we go any kind of route where we're using a payment third party, there's contracts and other things all involved. It is quite time consuming. It's a long haul process. I don't know how long exactly, but things take a long time to connect, and especially if it would be something in our new system, which is wonderful that we're building it now. However, changes and so forth, they take a while, and it's been in the works for quite a few years. So it would be a little far out for us to be able to accomplish something like that.
Yeah, I know that Affirm integrates really seamlessly with other payment systems. So I think, to me, the greater contract concern would be more related to federal dynamics of any payment processors working with the Schedule I substance. So that's where I wonder if the hitches would come up. But I think if we're going to do a cash program, and understandably, Amanda, it's going to be the hardest hit the first year, we will be one of the most inequitable licenses in DORA if we don't figure out a solution. So I hear it, but I think if there's anything that I would push for investment, it would be figuring out how we could get the most glaring inequity barriers addressed, and acknowledgement that a lot of them are going to take time. So heard on all fronts, but that was where originally my recommendation came from, was if we're looking at the most inequitable aspect of the state's dynamics, ones that we can only control so much, this could be a trailblazer way to put that burden on the facilitator, right? They're ultimately absorbing the cash burden of a platform like a firm to do interest-based payments over whatever time they can afford, monthly, quarterly, biannually. But I think figuring out some kind of solution for our limitations is really where my mind is at.
Thank you, Lundy. And I agree, and I agree with amending this to point to some kind of partnerships with some kind of private entity or multiple private entities to make this happen. Why don't we rework this for next time? And I think one thing we'll maybe consider next time is, in light of the concerns raised, is to say, absolutely must on day one, or is it to the degree feasible, or within a certain number of years? Or, I mean, your points are well taken. It's going to be the least equitable at the outset, which is a really bad precedent to set. But I just want to make sure we at least give the state some kind of way to succeed in implementing this with how we phrase the recommendation. Dr. Goodwin.
Just from like the human behavior side of this, one thing I like about mental health licenses is that, you spend 60 to 100 grand doing the masters, you do 2,000 supervised hours, you're working for pennies on the dollar for years, then you pay this money to get your license, and then you have to do continuing education every year, and then you have to renew it every year. And so there's a lot of skin in the game. And so when you look at disciplinary actions on, say, like mental health therapists, the percentage is pretty low. I mean, there are people out there doing things you shouldn't, but the percentage is pretty low because there's a lot of skin in the game. And I'm not 100% convinced that making it super easy and super cheap to get this thing is the best thing to do. I'm not saying we should artificially inflate it or deflate. I'm saying we should do everything we can to organically keep it low. But I don't know that bringing in a payment option where you could extend this out indefinitely to pay it is a great thing. I'm not convinced that that's there. And also I don't like it for all the other reasons of the cost that it'll do. And I just don't, I see what the intent is. I just don't think the juice is worth the squeeze. I think that the cost that it's going to add to this is actually going to cause more harm than good. And so I don't think I would be a part of this one. Thanks.
Share your perspective, Lundy.
Yeah, I just wanted to clarify that I'm not asking that the cost becomes cheaper. The cash program model makes it clear that the cost is what the cost is. The concern I have is the median income of the facilitators in Colorado. We are inherently favoring the rich if we don't create some kind of solution that makes this industry affordable. If someone's making $53K a year, a $2,000 license is a massive cost. So I think that we need to differentiate between a cheap license and just being able to afford to even enter this industry in the first place when we're looking at $5,000 education certifications potentially before they even apply for a license with the state, before they even get liability insurance, before they even open up their doors and pay for rent if they have a space of their own. So something I'm working on right now is an actual budget to show when we're talking about these potentially projected costs, what are we really talking about? And I'll have that prepared for November. But I just want to clarify, Dr. Goodwin, that I think we're on a similar page of protecting this industry from not being so easily accessible that people don't have to have skin in the game of participating. But then there's a really, really big skew we're talking about socioeconomically if we don't create any solution for the costs related to participating in this industry.
Thank you, Monty. Back to you, Dr. Goodwin.
Yeah, Lenny, I'm on the same page as you. And, yesterday during the subcommittee, the emergency response in Dr. Connor's code of ethics, he wants to cap the number the ratio between facilitator to client to 4 people. And I don't exactly know where that number came from, but that was kind of the standard. So 4 clients for every 1 facilitator. The concern there is, if you're doing prep, admin, and integration, you got 10 to 15 hours tied up into one administration session. You can only run 4 at a time by yourself. And then I don't know what the life cycle of a client's even going to be, right? So in therapy, you bring in a client, you're going to see them 10 to 30 times. It's psilocybin once, twice, maybe, and then once they kind of get a good feel, maybe they'll do it on their own with personal use. We don't know yet. We don't know what that looks like. And so I'm concerned the same. Like in your document, you're thinking this license could cost up to $10,000, a 5-figure number. Well, if you're running those numbers, you're running 4 clients, you're talking about making $20 an hour by the time the math works out. And if that's true, then this whole industry is going to collapse in on itself. Like, who's going to pay $10,000 for a license to get paid like a yoga instructor? And so, and really, that's driving all my decision making of any cost that we add to this could collapse this whole deck of cards. And so the idea is that, yeah, we want it equitable. I get it. People have trouble coming in with the money, sure. But all of these things do have associated costs. And we could be stacking this deck against them, even though we are trying to help them. And I am super worried about that, because I don't think that the math is going to work out on the back end unless you are a therapist or you have some other license where you're getting income from other pieces and you're adding this into your thing. I'm worried about those sole proprietor. I just want to facilitate. It's not looking good unless I'm reading it wrong or I'm not seeing something. But anyway, thank you.
Thank you, Sam.
I'll actually defer to Tristan.
Oh, thanks. So I want to bring up the timeline that we might be thinking of as well, and just sort of recognize that. So my suggestion is by far, it's certainly not perfect in any means, and it doesn't account for the first mover advantage that a brand new business does get. But since this is a cash program, there might be a reality where that first year there won't be any type of allowance for a payment plan because we do need to fill those coffers. But there could be something that we write as a committee that say that within 12 months of initiation of this, a payment plan does need to be developed, assuming that we've developed that cash budget that is required, and then that can allow for that type of on ramp. Of course, as I said, you lose first mover advantage with that, but it's a little bit of a balancing act that might prove useful. That's all.
Thank you very much. And I do think that there's at least theoretically a way for the state to implement this with a third-party payment processor that doesn't necessarily require additional state outlays or increasing the cost of licensing. I mean, that there would presumably, well, I guess I wouldn't presume, but if there's any kind of interest rate or processing fee involved with that plan, then that would be the vendor's compensation. Anyway. So I think where we are with this recommendation is we definitely don't like it as it is, and that we should revisit the idea of the state partnering with a vendor to implement a payment plan for licensees, some way, sometime, somehow. As best as this, we can find consensus to encourage the state to do so. So we will revisit this idea next time, and I don't know, Sam. Maybe we can get a better grip on kind of get a little more info about the PayPal thing. Just get a better feel for kind of what we're really talking about in terms of mechanics and costs with this alternative.
Yeah, happy to do that.
Yes, Dr. Goodwin.
Do we know, is it going to be renewed? I mean, are we going to renew it annually or every 2 years? Have they made a decision on that in the other subcommittees of what they want to do?
Renew the license?
Yeah, I mean, I'm sure there'll be renewal fees, right? So how often will that have to happen? Do we know?
I want to say it's annual in statute, but I have to double check.
Okay, that's all. Thanks.
Okay, so thank you all for that discussion. Let's move on to number 6. And so this recommendation came from me looking at the concept of, and we can narrow this back down to sharing, the state sharing data with insurance companies so that they can have more robust data about risks, so that they can have, better opportunity to bring down premium costs for their insurance products. And that had me thinking, and this gets really deep into the realm of the products and data subcommittee, but that why should we limit the availability of that data to insurance companies? Shouldn't this data, of course, in a de-identified way that 100% protects, the identity of individual consumers, participants in the program, make that data available to the public so that all, not just insurance companies, can have access to it. So that's where my head went with this, but I want to open it up to subcommittee member comment, questions, and feedback. Yes, Lundy.
As someone who was an advocate for how can we decrease insurance costs for facilitators, I think my one question is, does it matter? Does this actually have an impact on insurance companies opting in? And I just don't know that I've gotten a clear response from those within those worlds to know if this is even a worthwhile investment of a recommendation, or what would incentivize insurance companies to participate sooner and decrease premiums.
Thank you. Fair question, in my opinion. Matt?
Yes, in conversation with multiple brokers or carriers, the insurance world's complicated. There's, sometimes you think you're getting a policy from some company, it's actually reinsured by 3 others, but whatever. The point is, the data, the actuaries need data. That's what they're used to. They're used to a lot more data than they have right now. They have 0, and they're used to, gigabytes of data on, losses and costs and stuff. So anything we can give them would further the conversation. They're interested, they're listening. They just don't know what to do because they don't have numbers.
Thank you. That's a good point. I think it was this subcommittee that heard from 2 people who were interested in, with one company, I think, that were interested in getting in the insurance, liability insurance arena in this phase. Of course, that's not a guarantee, and that's just one company. So no doubt this is going to be tricky terrain in the near term. So I think that the gist of this as written is really, and I guess I would kind of modify the process for this recommendation, is really, do we want to make a recommendation from our equity lens to the products and data subcommittee that this is where we'd like to see things go in terms of the data more broadly? But that's, I don't know how the subcommittee feels about that. So that's an open question for your feedback. If we want to kind of signal that direction to that other subcommittee on this question, which I know they'll be getting into, I'm sure, if we really, involved discussion overall about what to do, how to collect this data, what the data will be, what to do with it once it's aggregated. Yes, Commissioner. I think you're muted as someone who is often.
Sorry. Honestly, I think everything that we do depends on data. And so if we can give data, it will help drive down the costs of the insurance because they see the risks have lowered So that's just my perspective is the more data you have, the better case you have for lower costs. Or it could work the other way too, so.
Good one.
I'm supportive of this too, and the way I read it is you're saying whatever we have, let's make it public, and I like that as long as we're not saying, let's make someone sit around and aggregate all this data for everybody else, and let's put money and time and positions into this. But if we have some good way to store all of this publicly, where these folks can go in and pull it out, and it's not a big administrative extra burden, I'm supportive.
Thank you for that. Other comments, questions about this recommendation? Okay, so if there's no further discussion on this recommendation, I would like to move to a vote. This is a reminder, voting discussion is light for members of the board. May I have a motion to approve recommendation number 6?
So moved, Dr. Goodwin.
Thank you, Dr. Goodwin. Is there a second?
Commissioner Buxton Andrade second.
Thank you, Commissioner Buxton Andrade. All in favor of this motion with the kind of addendum or amendment that the next step for it will be to present it to the products data subcommittee before it goes to the full board. All in favor?
Aye.
Aye.
Aye. Anyone opposed? Anyone abstaining? Okay. The motion passes. So we'll move to the next item, number 7. And so again, because it's brief, I'll just read it. In order to receive any license under the natural medicine program, an applicant must submit a brief social equity statement that describes their commitment and actionable plan to ensure equitable access to the services they provide. And so just noting, the reference to licenses, all licensees, just facilitators. Yes, Lundy.
So as a licensed mental health therapist, I am aware that there's actually been a strong negative reaction to this requirement in Oregon from the provider facilitator standpoint for a couple of reasons. First, that the burden of equity is being put on practitioners who themselves are experiencing inequity in the industry for how much it costs to access, and feeling like the burden is being put on them to figure it out instead of the state. And then secondarily, that it's impossible to actually be equitable under the current conditions that are put on providers. So again, that they're having to try and find solutions for the industry that the industry itself isn't finding. So I just think that we need to figure out, like, what are we actually asking for, and how could this actually promote equity? Or is this just a way of the state trying to feel better about having facilitators think about equity? So as written, it doesn't give me confidence that it'll actually promote equity in the industry.
Thank you for that. Tristan, yeah, please go ahead. And I believe that there is a line. You go ahead. I think you're going to say what I mean.
Oh, okay. Really just echoing what Lenny just said as well. We see it's called the social impact plan in Denver for the cannabis business, or for cannabis businesses, and I think they just switched it to Cannabis Cares or something along those lines. The reality is that it's somewhat performative, like at best. Like a group writes it, there's no teeth to it. There's no benefit to the group for following it. There's no punishment to the group for not following it. Consumers, whatever, and in this particular situation, participants or patients, like if they don't understand the benefit, if they don't know the efforts that this practitioner or business has taken to commit these social equity practices, they aren't making knowledgeable choices around it. So there's no real benefit to the group that's actually taking the effort towards these practices. It's a nice thought, but if there's no teeth, it doesn't do much. We've already seen it.
That is very helpful feedback, everyone. Thank you very much. So I'm inclined to scuttle this recommendation, unless there's any other comments or folks want to say anything further about it. Okay, thank you all for that. Let's move on to the next item. So now this things get, I think, a little, trickier here, but this is an effort to implement the recommendation that we've been cultivating over the last number of months around having a social equity licensure program that to some degree tries to learn from the social equity license program and the cannabis program in the state. The feedback that I think I have heard is that there's not currently a funding mechanism in law for this program. If there are objections to that conclusion, then please raise them. But if that is the case, then I think that the form this would need to take is that if and when there is revenue of any sort, and I've assumed here in the drafting of this, it would be tax-related revenue that could fund a program like this, then it should be adopted and implemented at that time. So with that said, I want to open it up for feedback and comments and questions from the board and non-voting participants. Yes, Sam?
I will say that we have to remember this is a regulated access model and not like cannabis business office with the retail model for cannabis. So I don't know like revenue sources. I don't know what like projections would be for it or how it would be funded. And I'm not a tax expert, so please somebody correct me, but I feel like this would either have to be a ballot initiative or something through the legislative process.
I definitely agree with that part. And I don't know when. I mean, I guess this is my best effort to capture this idea, which I at least support. Acknowledging though that currently and in probably the near future there is no apparent funding mechanism for it. I'd be very happy to be wrong about that. That's what I've heard and seen so far as it relates to this concept. Dr. Goodwin.
The one issue I have with this is that when you say social equity licensure program, right? So you're thinking communities who are, minorities, folks with disabilities, right? Indigenous youth, all this kind of stuff. But this is like the majority of people who are using this product. It's like, because it is a mental health service that we're talking about, this regulated model, right? So it's not the recreational use of like cannabis. Anyone's using it for recreation. We're talking about, programs where folks are coming in to get help. And so it seems like the 80% would fit into this program model, right? So I guess I don't understand why we have it. That's like a veteran company giving a military discount when all they serve is veteran. Well, if like all of your population is part of this program, so let's just keep the cost low instead of calling it a discount. Does that make sense? Or maybe I'm seeing it wrong, but
let me let Tristan, because we've had some ideas about trying to learn from what the cannabis program has done in this regard in terms of the criteria by which people would qualify for the types of support that would be offered. And so I think maybe Tristan, you're best suited to.
So I guess a couple things. First thing that, just throwing it out there, the first thing that comes to mind here is that there's no provision on ensuring that the amount that is set aside is enough to be impactful in some way. And, you know, I realize that we can't put that amount there, but even if we could tie it to just referencing, you know, similar parallel successes, that might just be helpful. When it also, I can speak a little bit to the tax dollars just from the perspective of the CBO, right? So we are entirely funded through the marijuana tax cash fund, not the general fund, which does allow for some additional allowances in how this goes. I do agree that it almost certainly requires a legislative action, but I don't believe it would require. If this program is going to set up its own tax cash fund, I believe that allows for direct legislative action that is sort of outside some of these table rules. So just something to consider. And as far as, you know, defining social equity, I don't want to speak too much from the cannabis business office perspective, because a lot of that mentality came from the clear impact on, you know, over policing in a disproportionate manner in specific communities or over others, right? And that's obviously not the only effect that, you know, the war on drugs had, specifically related to cannabis, but that was like that really clean story that could really unify people and get it to pass. I think this was mentioned several meetings ago, but we don't know if if the same disproportionate impact has occurred as a result of the prohibition of something like psilocybin as what was the result of the prohibition of cannabis. So I'd want to be really careful that when we start looking at was ultimately the correlative factors of whatever demographic we're trying to support, that we do tie it to the impact of psilocybin prohibition or broader natural medicine prohibition, and not just cannabis, especially given that cannabis was its own beast, given it's very easy to pick up, right? You have the smell of it. It was very easy to arrest people for cannabis possession. So that'd be the one thing that I want to throw out there, and we just be really careful with. I'll stop for now because I tend to ramble.
That's super helpful feedback and context. Well, let me just other feedback, questions, comments about this recommendation, whether in response to what's been said so far or otherwise. Yes, Tristan.
Sorry, I did just hone in on the household wealth. So some background on what we're seeing with the social equity criteria in the cannabis space, at least when it's tied to personal income, it turns out that, you know, wealthy individuals with access to good CPAs can make it look like their personal income is very low, even though their assets are very high. So we're actually seeing a number of individuals qualify when they do not in any way meet the spirit of that qualifying condition or criteria. So just want to highlight that. I think it'd be very helpful to really go through and find ways to break any qualifying criteria, understand that it will be broken and that you will deal with significant public backlash from a number of different groups, which is something that we do right now in the cannabis space.
Thank you. So one thought I have is that given that I think there's consensus that this is not something that can be implemented on day one, my suggestion is we table this to work on it a little bit, not just a little bit, maybe, you know, this could be years to really try to get this, you know, into something that will be helpful and feasible and funded. So I don't think there's any urgency to vote on it now in light of all the comments that have been raised, and don't think we should vote on it. So anybody have any concerns about that? I do want to continue to examine this possibility, although I do think that funding wise, it's not going to be, you know, I don't see an apparent way that it could be applied on the first year of this program. So I think that might make it a bit of a lower priority than some other ideas within our programs. Okay, with that, let me move on to the last one. This stems from two things. One is well, I think that we've had a recommendation along these lines brewing, but I also know at the subcommittee where there's been talk about the independence of the facilitators from healing centers, and that currently, at least as I synthesize the conversation, the one reason that facilitators might not be able to deliver services independently in healing centers is because they're not able to get natural medicine directly from cultivators. The healing centers need to do that, so the facilitator relationship with the healing center to get the natural medicine to furnish to the participating patient. So this is a recommendation in the spirit of equity. I don't know which direction that subcommittee is going. Maybe Sam or others do. That we might recommend that ambiguous phrase be clarified. Yes, Sam.
Yeah, I think clarification would be helpful. I think it's also, we need to figure out, we know Oregon, I think, doesn't permit it, and it's actually been helpful for facilitators not even handling product to be able to have liability insurance. But I think it makes sense to create a pathway for the facilitator to do that if we're going to be offering at-home facilitation, right? The question comes into, how do we make that work with storage of the product, and how that's reflected in inventory and manifests? Would they be operating similarly to what a service center or a licensed premises would have to do with product, as well as cultivators and testers on the distribution and where the product is going, and how that's reflected in the manifest when it's traveling? So I think it should be allowed. I think we need to figure out those pieces on how we can make it work, or if it's an optional piece, right, for facilitator if they wanted to operate outside of just a healing center, and the requirements there. I think we also on the storage piece, we got to really figure that out, because I'm really concerned about, if a facilitator is allowed to, have product directly from a cultivator and then going home, and then where's that locked up? Where's that safe? What if they have roommates, right? Or kids at home or anything like that? Like, those are the things that we need to be really careful. And I know, especially with what historically with cannabis, were a lot of the concerns that DOR had heard for safety of product and how that's tracked, and access for children was like one of the main concerns the DEA had, right? So we have to figure that nuance of like how a cultivator could have this, and we're also making sure we're doing this as safe as possible. Is it maybe they go to a healing center and store it there? I don't know if that's best, but like we have to think about those options where we're creating opportunities for facilitators to be able to do that. If we're going to be doing not just healing centers or licensed premises, but also at-home facilitation.
I think those are excellent points. So I want to see if other subcommittee members or non-voting participants have other things to say. I want to offer, in light of that, a potential, if we do want to move forward on it, a modification that we're, as with one of the other recommendations, this would be a sort of a sentiment expressed to the licensing, if I'm right, whichever is the appropriate subcommittee. I mean, I don't want it, because either products or licensing. That this is the kind of direction that the equity subcommittee would like things to go in the spirit of equity, but perhaps acknowledging that there are a lot of details that need to be considered before kind of that pathway could be finalized and implemented. So in other words, relate it to that other subcommittee before submitting it to the full board. Dr. Goodwin.
Yeah, I like this one. And you're right, just like it says, let's build a pathway to make it happen. Whatever that is, we can work out the details later, but I do think they should be able to go get it and use it, track it. It's good.
Yeah, and just to echo real quick, I think like also it's, if that is the pathway that they are going, then they're going to have to adhere to the requirements related to that, whether that is tracking inventory management, if they have to enter where they're going or who they're giving it to, those pieces, as well as like what's done with excess product after, right?
Great. Okay. Yes, Rochelle.
Thank you. I just wanted to share that the BHA in licensing methadone clinics does have a set of rules for scheduled substances in which they receive, log, control the substance under lock and key. There's 2 people under a shift change that would count the medication and verify the count, and then transfer that lock and key over to the other staff members. So there are some procedures in place that we have regarding that type of medication. And then also in my training for ketamine assisted treatment, that medication is allowed to be sent to the client, and the client is dosing themselves. And I know we couldn't use federal mail for psilocybin, but it could be a consideration that the client is able to pick up their own medication as well. So I just wanted to throw out some of those options to the board.
Thank you. That's helpful to know that there's been some precedent for this. Okay, any other discussion or questions about this particular recommendation? Okay. I lost my script, but I basically would like to call for a vote on the recommendation with the caveat that we are voting to refer it to the appropriate subcommittee that's been working on this issue before it goes to the full board for further consideration.
So moved. Dr. Goodwin.
Thank you, Dr. Goodwin.
Second, Lundy.
Thank you, Lundy. All in favor?
Aye.
Aye.
Anyone opposed? Any abstentions? Okay, the motion passes. Thank you all very much for working through this list, and you'll have more to come. And I do want to invite subcommittee members to share with Sam, recommendations and issues that you want to prioritize for the next meeting, so we can pool all of that and move into some of the other areas that are on our list next time, as well as continue some of the threads that we tabled at this particular meeting. So I'd like to move on to agenda item number 4, which is to approve and discuss future meeting dates. The next meeting is next Thursday. No, whoops, I might have an old version. It's in November. Does anyone have the date offhand?
It's the 9th.
Okay, November 9th at 1 p.m. Mountain Time. Does this still work for everyone? Lundy.
I will be out of office that week, so I just wanted to see if there would be quorum without my presence at that meeting.
So I think I might actually, I do have a family matter that day that actually I would really prefer surgery for a family member that is. So I would like to move the date too. Actually, other subcommittee members are okay with that. So,
Would Monday have been the week following, or the 13th, or the 14th?
Both dates work for me.
Yeah, they work for me too.
Mondays do not work for me.
Okay.
Tuesday works better for me.
Okay. 14th.
Not work for me.
I can't do Tuesday the 13th either.
Busiest days.
Do you have quorum with Dr. Goodwin and Dr. Gonzalez and Billy?
Yes.
I can't do the 14th.
We do. And if I say we just go ahead and hold that date, and if we can't meet or if we lose quorum, then we will send out a Google poll. And we can do that after this meeting as well, but let's just go ahead and hold a date to confirm.
To be clear, we're doing the 14th or a hold.
14th, yeah, at 1 p.m.
And just so you know, Sam, I will for sure be there. That's my board meeting, so it trumps everything else.
Okay, thank you.
Do we need a motion to adopt that schedule change?
Yeah, let's just go ahead and do it.
Okay. Is there a motion to move the date of the next subcommittee meeting?
So moved, Dr. Goodwin.
Thank you.
Seconded, Lundy.
Lundy, all in favor?
Aye.
I
Okay. The next date of the subcommittee will be on that Monday, the 13th. At 14. 14.
Tuesday. Tuesday the 14th.
We're getting there, y'all. It would be Tuesday, November 14th.
You're good.
Thank you all. Okay. As you can see, the coffee shop I was in closed, so that's why.
No, you're totally good.
But I've got a script here. Or go ahead, Sam. You have something else to say?
Yeah, so just attestations now, and then we can close out.
Thank you. Okay, thanks everyone for your attendance and participation during today's meeting. Before we adjourn, there are a few items to be addressed. We've already said the next meeting. I'd like to ask for these attestations to attest and affirm that all conflicts of interest have been disclosed and the confidentiality of all board matters has been maintained since the previous board meeting. I do so attest. Dr. Gonzalez.
I attest.
Thank you. Lundy.
I attest.
Thank you. Commissioner Buxton Andrade.
I attest.
Thank you. Dr. Goodwin.
I attest.
Thank you. Is there a motion to adjourn the meeting?
This is Commissioner Buxton Andrade. I make a motion to adjourn the meeting.
Thank you.
Second.
Is there a second?
Dr. Goodwin.
All right. All in favor of adjourning the meeting, please say aye.
Aye.
I
Aye. Anyone opposed? Any abstentions? This meeting of the Public Health and Public Equity Subcommittee is adjourned. Thank you all very much.
Thanks, everybody.
Thank you.